Good evening. Welcome
Mhm.
to my IVF Answers and the European Fertility Society. We are back once again this week for another webinar and another topic and another fertility expert. So you can see her right here. Dr. Viktoria Mokhnii is with us. So hello, Dr. Viktoria. Lovely to have you. This is your first webinar with us. I'm glad that you are joining this an amazing team of experts. So thank you already for joining us. I hope you're feeling okay and are ready to educate us, discuss hysteroscopy, a very difficult topic as well. But I'm glad that we are going to talk about this today. And I hope that you are feeling okay and are ready to share some of your experience and also some of your knowledge, of course, as well. How are you?
Hey, I'm fine, thank you, Caroline. Hysteroscopy is very interesting thematic and very successful one in the treatment of infertility patients. Give us tremendous and amazing information. It give us successful protocol to treat them and have a successful pregnancy. So very nice to see you, and I'm very happy to be here with you. And I hope Ukraine will be soon on the top and will be developed like before.
Definitely, we are all rooting for that. That's for sure. So thank you so much. The Dr. Viktoria is the gynecologist and reproductionalist from Ekstramed, which is located in Ukraine. So we are happy to have you here indeed. And now we are about to start with the presentation on our topic. But afterwards, remember there will be time for your questions. As always, you just need to put those in the chat. And after the presentation, Dr. Viktoria will definitely take care of those questions for you. Remember, this is being recorded and it's all anonymous, so feel free to ask anything that's on your mind. We are simply here to support you and educate you as much as possible. And I believe we can start with the presentation. Dr. Viktoria, are you ready to begin with your presentation?
Yes. Mhm.
Okay, so let's start. We just need to start the slideshow so we can
Mhm.
see fully, and it should be all okay.
Mhm. 1 minute.
It may take a second or two, but should be all okay.
Slideshow.
Mhm. From beginning, and I think that, yeah, now we can see it very well, so it's all okay. Thank you.
The exceptional role of the hysteroscopy in the diagnosis of infertility. In our clinic, we have a personalized approach to each couple with infertility, but hysteroscopy is favorable before each program of IVF, before each IVF program for a successful pregnancy. Is the hysteroscopy associated with an increase in live birth in a patient with normal transvaginal ultrasound results? Recent research and experience of our clinic, definitely yes. We're talking about published study on February 24, 2022, covering the period from 2017 to 2020. Clinic of Great Britain and Greece took part was 334 patients, and conclusion of the study was a higher percentage of successful of live birth and successful pregnancy was obtained in the group with hysteroscopy performed before embryo transfer, 42% versus 26% without the hysteroscopy. So the purpose of this presentation demonstrates that screening hysteroscopy increases the percentage of successful clinical pregnancy with normal results of transvaginal ultrasound of the uterine cavity. Hysteroscopy is the current and extremely informative diagnostic method of the uterine cavity, which increases the percentage of embryo implantation and successful pregnancy. Currently, hysteroscopy is the only method that can be used to diagnose physiological and pathological changes in the uterine cavity and endometrium for successful treatment protocol. In the comparison with the normal results of ultrasound diagnostic, uterine cavity minimal intrauterine abnormalities during hysteroscopy we detect up to 45%. And if we have failed IVF protocol, IVF program, this is percentage even higher. Hysteroscopy is usually performed under short anesthesia uh, for the relaxation of internal os of the cervical canal for shorter time than without the anesthesia and absence of pain. Over the past decades, we have made significant progress in the IVF field. Implantation failure refers to condition where the embryo fails to attach and implant into the lining of the uterus, resulting in the inability to establish a successful pregnancy. Implantation failure after ICSI and IVF, it's a we don't achieve clinical pregnancy with the good embryo transfer technique and high quality embryo with a high potential for the implantation. Implantation failure, briefly, are associated with embryonic and maternal factors. Maternal factors, uterine abnormalities, myomas, fibroids, chronic endometritis. It's a big issue like uterine factors for the successful pregnancy, hormonal imbalance, secondary and primary thrombophilia, embryonic factors. Embryonic factors is embryo should have high potential to implant, and this is very, very important. And KIR-HLA for the maternal fetal incompatibility, I'm sorry, is very important too. So for the to show, demonstrate how important is the hysteroscopy in the like diagnostic method for the successful pregnancy, I have some clinical cases. And clinical cases number one, and 27 years old female patient with 5 years of infertility history was operated on right tubal ectopic pregnancy 3 years ago, right fallopian tube removed, normal vaginal microflora, PCR test not detected sexual transmitted disease except uroplasma parvum, positive test result, bacteriology culture of urogenital pathogenic flora not detected, hormonal screening within the normal range, vitamin D3 normal 43, IMH normal 4.3, general urine test normal, primary thrombophilia mutation negative, antiphospholipid syndrome is the normal range, CT56 202, showing represent the aggressive immunity during the embryo implantation, CD56, CD128. A few represent the chronic endometritis, and this is two CD56 and CD128, they correlate with each other. Sometimes when we have chronic endometritis, CD56 higher and CD128 is negative. KIR-HLA, low reproductive losses. Medical history patency, the left fallopian tube was diagnosed during laparoscopy and also confirmed by metrosalpingography in 2021. Normozoospermia, plasma treated with doxycycline, 100 milligram 2 times daily, 15 days, both with the partners. It's very important too because the microflora is common between two people living together. Uroplasma parvum after treatment not detected. Doxycycline is recommended for the treatment of chronic endometritis. And the one lead things what not to tell us maybe we have chronic endometritis, it was the basal membrane, was thickening of the basal membrane in the proliferative phase. Proliferative phase should be with very clear endometrium on ultrasound, on transvaginal ultrasound, and strain ratio was 0.58. It's a higher strain ratio than should be, so we can think maybe she had chronic endometritis, and this is the uterine factor for the infertility. Patient knows that the left fallopian tube is a patent and has been trying to get pregnant for 3 years. And to the For the decide for successful treatment protocol, were decided to do screening hysteroscopy. I will get back to this slide. So this was the hysteroscopy of patient number 1. We can see the abnormal uterine cavity. Endometrium hyperplasia. Here is the synechia, micropolyps, polyps. We cannot see this like this cavity on the ultrasound, transvaginal ultrasound. It was not possible to see this, not possible to diagnose the uterine factor of infertility. So this is the synechia, micropolyps, hyperplasia, hyperemia, and strawberry spots. The all signs of chronic endometritis. And the most important, you can see here is no left tube open to the uterine cavity. So the patient knows for 3 years the left fallopian tube is working, but actually no. So we use the resectoscopy for treat the uterine cavity, to remove the synechia, to remove the micropolyps and polyps. Polyps in patient, if the patient would do the hysteroscopy 3 years ago, he would save the time and no depression, and try to get pregnant successfully. So this is very important. I'm sorry. I cannot get back. 1 minute. I need another slide. So diagnostic hysteroscopy is recommended. Diagnosis after the hysteroscopy, uterine factor of infertility, chronic endometritis, we can see it's clearly, it's not normal uterine cavity, multiple polyps on the uterine cavity, synechia, obstruction of the fallopian tubes. Treatment protocol, hysteroresectoscopy of polyps of uterine cavity, synechia, areas of hyperplastic endometrium, irrigation of the uterine cavity with the antibiotics number 10 every second day, and general anti-inflammatory therapy, assisted reproductive technology. At the moment, the pregnancy is successfully prolonged, 25 weeks. Conclusion, the uterine factor of infertility is diagnosed only during the hysteroscopy. This patient was treated with doxycycline before the hysteroscopy. So usually the regular therapy for the chronic endometritis and doxycycline did not treat the uterine cavity, and we saw this abnormal cavity and not possible with this cavity to get pregnant. On this picture, we can see the strain ratio 0.8. I will explain later about the strain ratio. Clinical case number 2, a 34 years old female patient with 11 years of infertility history, had a 5 failed IVF program with PGS, pre-implantation genetic screening, genetically healthy embryo recommended for embryo transfer, submucosal uterine myoma. It's from the history. There is a history of hysteroresectoscopy with uterine polyp removal. PCR test no detected sexual transmitted disease. Bacteriology culture of urogenital flora detected Enterococcus faecalis in the concentration higher than should be. Primary thrombophilia mutation and antiphospholipid syndrome are negative. Hormonal screening within the normal range. Basic prolactin is very, very important in patient who has myoma, because prolactin increase the sensitivity of estrogen receptors and make the myoma fibroids grow faster. Vitamin D3 is very important in patient who has myomas, should be normal level always. So here is the 17 low level of vitamin D3. It's very important to put it up for the slowly for the treatment of myoma and fibroids. Transvaginal ultrasound, submucosal uterine myoma with slight deformation of uterine cavity. So we cannot see 100% the myoma going into uterine cavity. Strain ratio high, 1.1. The strain ratio normal should be around 0.2, 0.3. This is very successful, good strain ratio of good quality of endometrium for the successful pregnancy. CD56 to 46 elevated represent aggressive immunity during the embryo, during the implantation. CD138 are negative, therefore negative. Here HLA showing the low reproductive losses. We decided to do hysteroscopy for the treatment and diagnostic of the pathology and pathology of uterine cavity, and for the treatment, successful treatment and successful pregnancy. Here is the hysteroscopy of the patient number 2 and resectoscopy. So we can see the fibroids, myoma fibroids on the posterior wall of uterine cavity. We can see the strawberry spots. We can see the abnormal uterine cavity, of course, hyperemia. It is on the myoma, dilated vessels, where is present always and has a big impact of successful pregnancy and successful implantation. We did intracapsular myomectomy technique with the preservation pseudocapsule. This is very important for the healing of the myometrium and endometrium, and then for the receptive endometrium and successful pregnancy. You can see the chronic endometritis, and I remind you, CD138 were negative. So we did resectoscopy of fibroid very successfully. Myoma FIGO type 1. So it was easy, and we treat the uterine cavity for one time, remove the fibroid. With the Gubini resectoscope, bipolar resectoscope. It's very important too. Bipolar resectoscope give us the cavity without synechia. Okay, so on hysteroscopy diagnosis, after the hysteroscopy diagnosis, submucosal uterine myoma, FIGO 1, chronic endometritis. Hysteroresectoscopy was performed using the intracapsular myomectomy technique with preservation of pseudocapsule, which ensures good wound healing and muscle recovery. Endometrial receptivity is very important. Currently, hysteroresectoscopy is considered the gold standard for the treatment of FIGO type 0 and type 1 uterine submucosal fibroids. A bipolar resection of submucosal fibroids is recommended. Monopolar resection increases the risk of the intrauterine postoperative synechia. So the treatment protocol of patient number 2, intracapsular myomectomy, anti-inflammatory therapy considering the sensitivity to antibiotics of Enterococcus faecalis. Vitamin D3 is very important. 5,000 international units daily, 3 months. Assisted reproductive technology. Vitamin D3 is considered as the potential therapy for the treatment of the uterine fibroids. Contextual search was conducted in the Cochrane Library, Embase, PubMed, Scopus, and until March 2022, 960 publications were processed. Vitamin D3 reduces the proliferation of myofibroblast, decreases the expression of the extracellular matrix protein, stabilizes cellular hemostasis. Pregnancy achieved, very successful pregnancy from one time achieved by assisted reproductive technology, attempt number 6 in our clinic. It was the first attempt. Prima gravida, 16 weeks of the gestation, successfully prolonged. We were very happy with this patient. So shortly, the relationship uterine fibroids and infertility. Uterine fibroids are benign tumor formation from smooth muscle cells, myofibroblasts, and with large number of components of the extracellular matrix. Fibroids have a high content of collagen, rigid structure, strain ratio 2.5 to 5. The growth of myomas depending on estrogen and their receptors. Estrogens support the expression of progesterone receptors and inhibit the factor P53, which is the tumor suppressor. Submucosal uterine myoma in relation to infertility, the formation of the uterine cavity, we saw this on the video, violation of the blood supply to the endometrium and myometrium, strengthening the uterine contraction. Uterine JZ zone, junctional zone, is the source of contraction of the myometrium and endometrium, a place of expression of estrogen and progesterone receptors. Hormonal on molecular changes, cytokines, interleukin 10, tumor necrosis factor, violation of the receptivity of the endometrium in gene expression. The expression of hoxaten and glycodyline is reduced during the embryo implantation at the submucosal fibroid. This is very important. Hoxaten and glycodyline is very, very important, and without them, no successful implantation. Increase of the vascularization with dilated vessels and chronic endometritis. We can see this on the video. It was chronic endometritis and CD 138, which the sign of chronic endometritis were negative. The correct diagnosis. 1 minute. So, clinical cases number 3, 28 years old female patient with 8 years of infertility history, had 4 unsuccessful attempts of IVF program with donor eggs, karyotype of this patient with certain anomalies, translocation of areas of chromosome, PCR test not detected sexual transmitted disease, urogenital bacterial culture, Staphylococcus hemolyticus at a higher percentage than should be, primary and secondary thrombophilia tested negative, CD56 normal, 157, CD 138 negative. Here HLA low reproductive losses, hormonal screening without normal range. This patient was surprised to all of our team of our clinic. For embryologist, for director, for me. So transvaginal ultrasound of the uterine cavity showing beautiful endometrium, secretory endometrium 9 millimeters, strain ratio 0.28. The pathology is not detected. Strain ratio is the index of tissue stiffness when comparing endometrium and unchanged myometrium obtained using ultrasound compression elastography. We're doing this in our clinic. This is very successful technique to show us quality of endometrium, and mostly we got successful pregnancy using this technique. The Gardner grade 5 AA embryo is recommended for the transfer with big potential, and blood test after 8 days after the transfer were negative. So we decided to do the hysteroscopy, diagnostic hysteroscopy, to see what is the problem. And diagnostic hysteroscopy was after unsuccessful embryo transfer with all situation I described before. This is the diagnostic hysteroscopy. It was shocked. It was diffuse endometrium hyperemia. We did not see this on ultrasound, transvaginal ultrasound, no one time. Endometrial micropolyp, endometrial stroma edema, and hyperplasia, and strawberry spots. We can see the strawberry spots all over the uterine cavity. So here it cannot be possible to have a successful pregnancy with this cavity. Chronic endometritis are non-symptomatic and have low-grade symptoms, sometimes in dysfunctional uterine bleeding. This patient did not complain to anything of this, so we were sure everything is okay here. Okay. So we did complex anti-inflammatory treatment, and I will show you the uterine cavity after the treatment, and this is the relationship of chronic endometritis and impact on fertility. This is very important. Chronic endometritis is a very important issue, so we can diagnose mostly on the diagnostic screening hysteroscopy. This is the condition where the peaceful coexistence between microorganism and immune system in the endometrium disturbed. CD128 has no correlation with endometrial bacterial colonization. Inflammatory mediators in the endometrium, leukocytes, immunoglobulins, cytokines have an important role in the trophoblast implantation. There must be balance between T2 and T1. Endometrial proliferative phenotype during the chronic endometritis, increased estrogen receptors and low progesterone receptors, and Ki67 expression. Proceeds without symptoms and complaint. And diagnostic hysteroscopy shows a high diagnostic value for the successful treatment, for the successful pregnancy, after the treatment. So this is diagnostic hysteroscopy after the treatment, patient number 3. This is the beautiful uterine cavity. We achieved the pregnancy. We were happy with this patient, and she was too. So for this moment, the pregnancy successfully end with the healthy baby. So this was one more time to show in the importance of diagnostic hysteroscopy for the successful pregnancy. Conclusion: hysteroscopy is the gold standard for the evaluation of the intrauterine pathology and the condition of the endometrium to identify the causes of infertility, and is recommended before assisted reproductive technology program. Hysteroscopy is the gold standard and the only method for the surgical treatment of submucosal fibroids before IVF program. In the practice of the reproductive specialist, hysteroscopy is an extremely informative method of the uterine cavity assessment. See and treat. Hysteroscopy is the most successful diagnostic and treatment protocol before IVF program, which is recommended before embryo transfer to obtain successful pregnancy. This is all pictures on our presentation created by the artificial intelligence. The pictures showing the strong connection between hysteroscopy and life. So thank you for your attention.
Excellent. Thank you so much, Dr. Viktoria. That was a very thorough and very interesting session indeed, and presentation with lots of different details. So thank you so much for preparing this. And now, as you know, it's time for your questions. There are some questions right here already. However, if you haven't asked yet, this is your time. Let's go ahead with the questions. And here's the first question from Izette. There are two parts of this question, so I will show you all the different, all the details. Sorry. So I have undergone 4 transfers with different donor. I had 1 miscarriage, 3 negatives. I plan to do another transfer using ERA. Would you recommend undergoing a hysteroscopy? I am fully completed with menopause, no period since last March 2022. Any advice?
This is the same patient. This is the same question. Yes.
Yes, this is the same patient.
I recommended hysterectomy.
Hysteroscopy.
Yes. 100%. You should do the hysteroscopy because it will show of the presence of chronic endometritis, and you should treat chronic endometritis before successful embryo transfer, because if you do have inflamed uterus, you never get successfully pregnant. It will be miscarriages, will be biochemical pregnancy, but not successful pregnancy. We're always doing hysteroscopy. We love to do before the embryo transfer, secure and ensure us to have successful pregnancy and happy patients.
Okay, thank you so much, Lizette, for your first question. Thank you, Viktoria, for explaining.
No period since last 2022, so this is not a problem. This is not the cause of not doing the hysteroscopy and not secure you to have a healthy uterine cavity. So you should do the hysteroscopy definitely. And here is the here is there was miscarriages. So definitely, I think you had the chronic endometritis. The
Okay.
treatment of chronic endometritis should be like complex, because sometimes it's very hard to treat.
Okay, and there's a follow-up from Lisette again. So let's see. So is it worth to do it in a month before the transfer and in combination with the ERA test?
Yes. I will doing with the 1 month before the embryo transfer in combination with ERA test. ERA test successful with the 3 samples. 1 sample of ERA test not successful.
Okay.
For them knowing the exactly time for embryo transfer, for the development of the pinopodium, you should do 3 samples. I don't know where you from, and if it's possible in your country to do 3 samples of ERA test, but it's more give us more answer for the start of pinopodium and the regress of pinopodium. One time only showing yes or no. So better of 3 samples of ERA test give us successful pregnancy.
Okay, and there's a thank you very much from Lisette. And of course, if you have any follow-ups or any other questions, you know what to do. Thank you so much.
For successful pregnancy, in your case, I will be very quick. So you have to have negative infection, sexual transmitted disease. You have to have negative hysteroscopy. I'm sorry, and you have to have exactly time for the transfer in embryo, and good quality embryo with high potential for the implantation.
Of course.
Uh,
Yeah.
Pressure, how much?
Okay. Sorry, I am in US, but doing this in Barcelona. Okay, got it.
So I
All
wish you
right.
good luck.
Best of luck indeed, as always. Can you have a look at this question? Pressure, how much?
Which
I'm not
in
sure here,
diagnostic
sorry.
and which media ideal as a doctor? Yes,
Yes.
pressure, how much diagnostic? Sometimes we have uterus sometimes expand very well, and we can see everything. We can see the fallopian tube open. We can see very clearly everything. Sometimes the uterus did not, if I understand this right question, sometimes uterus did not, like rigid uterus. We need more pressure. We're going with 150 to see very clear the uterine cavity for the image of everything. So we try to do as much pressure as we need to see everything. 150 sometimes.
And thank you. If you have any follow-ups, let us know or type this in the chat. Right now, there's one more question. However, if you have more, you know what to do. We still have time for the questions, so don't hesitate. This is your time. This is your chance to ask the questions. So what is the maximum recommended time to do a frozen embryo transfer after hysteroscopy? Is 3 months too long?
What is the maximum recommended time to do a frozen embryo transfer after the hysteroscopy? 3 months is prolonged. No, if you have healthy uterus, you can see it's okay. So it can be 3 months. But if you treat uterine cavity with antibiotics, you see the inflammation. So 2 months is preferable
2 months.
after the hysteroscopy.
Okay, thank you. And let's have a look. Someone is typing, so we just need to give it a minute and wait for another question, possibly. So let's give it a second and see more questions. And in the meantime, remember that if you wish to get some more details, and as you know, during the webinar, it's hard to give a thorough answer. Remember, you can always get in touch with Dr. Viktoria and her team at Ekstramed. They will be happy to help you. I am sure of it. So don't hesitate. You can get in touch with them directly, or you can simply send me an email. My email address is in the chat, and I'm sure Dr. Viktoria and her team will be happy to help you. And let's have a look. We did receive more questions. So here's the next one. So is hysteroscopy more diagnostic than ERA test?
No, it's a different issue. Hysteroscopy showing the information in the uterus, and possibility to have successful pregnancy if it's no inflammation. So it's super. If it's inflammation, we should treat before the embryo transfer. Error test, it gives us exactly an idea when to transfer the embryo. Sometimes we have short window of 12 hours, and we need to exactly know when to transfer this embryo. Sometimes if it's a long window of implantation for 3 days, then it's okay. So the error test is completely different test than hysteroscopy, and give us it's like next step to have a successful pregnancy.
Okay, brilliant. Thank you so much again
You
for.
should do hysteroscopy and error test, and you should have negative sexual transmitted disease and hormonal imbalance. If you're not pregnant with all of this, then we should do maternal fetal incapability with genetic of the uterus and genetic of embryos. This is very successful test too, and give us idea how to do prepare for the successful implantation of the embryo with immunoglobulin. Immunoglobulin give us a therapeutic approach to have successful pregnancy too.
All right, brilliant. Thank you. And let's have a look. One more question we did receive just a minute ago. So, if you've had one hysteroscopy, normal findings, biopsy negative for chronic endometritis, but then have recurrent implantation failures, would you do another hysteroscopy, right? After 12 months?
So the recommendation is always, if you have the hysteroscopy, to ask doctor about video files, because then it give the possibility to another doctor to see what this doctor see. Maybe this doctor say he don't know any like problem with the uterine cavity, and for him it's a normal uterine cavity and is no problem. But for another doctor, it will be like the sign of the chronic endometritis, and doctor said no, absolutely not, it's not normal uterine cavity. So if you have the video of this hysteroscopy, give the look to another doctor, and maybe you don't need another hysteroscopy. But if you prepare to have successful embryo transfer, then of course you have to exclude the infection, sexual transmitted disease, normal hysteroscopy, ERA test, and healthy embryo with high potential to the implantation. But always video, always ask the doctor about video. It's give another doctor to chance to not do another hysteroscopy, because said we have this like experience with this, like we have beautiful embryos, and patient came from another clinic with the hysteroscopy on the paper and saying everything is okay, everything is normal. Then we transfer one embryo, then second embryo, then oh my god, we needed to find the causes of this issue, why she did not get pregnant, and we saw the hysteroscopy, it was inflamed uterus. So I don't know if it's like another inflammation, or it's doctor do not know this and say it's normal. So if you have a video, it's exclude this question and no problem, then we can decide successful protocol.
So it's definitely crucial to always ask for that
Yes,
video.
for the
Okay.
video, always.
Thank you so much. Definitely a good advice here. Just remember, everyone, that this is possible and it might definitely help. Brilliant. Thank you so much. Okay, next question we have. Please, can you explain what course of treatment you provided your patient with uterine fibroids, case 3, which resulted in healthy uterus?
Please, can you explain what course of treatment you provided the patient with uterine fibroids, case 3, case 2, fibroids, uterine fibroids, case 2? So intracapsular resectoscopy with myomas, with preservation of pseudocapsule of fibroids. And then we got treatment of chronic endometritis with irrigation of antibiotic into uterus. Always successful treatment to have healthy uterus for the successful implantation. And more specific question about what you mean about treatment. So we did remove resectoscope with bipolar resectoscope of Gubini. We did removed the fibroids. We treat the chronic endometritis complex with the sensitivity to antibiotics with microflora on the with microflora, and we correct her hormonal treatment. Her vitamin D was low, so we give the vitamin D. It's make us successful to vitamin D, very important to successful implantation. It's receptors in endometrium and give us successful implantation too. And we give her decaptil, if you know, this treatment to suppress of development of myofibroblast, and had one embryo. In this patient, we have one embryo and transfer this one healthy embryo and got a healthy pregnancy. So we are very happy with this case. If you have more question, I can answer you for everything.
Sure. Thank you so much indeed again. And we have another question from the same patient named Jay. I had a number of very painful embryo transfers, then had a hysteroscopy, and next transfers was painless and easy. Will this affect the last one?
I had a number of very painful and then had the hysteroscopy. You mean the hysteroscopy like open the cervix internal, or can be strengthening the canal of the cervical canal? Yes. And after that, it was the treatment. If the painful embryo transfer, it can affect the successful implantation, because the embryo transfer should be as much as possible painless and very quick, for 1 minute. We are trying to do this, always prepared for the successful embryo transfer with no pain. We're doing some medication to relax the cervical canal, and of course we know how to move catheter before to prepare for this. And if you have painful embryo transfer, can affect the success of the embryo transfer and successful pregnancy.
Okay.
If I answer right, I don't know if I understand.
I think so, of course. But if you have any follow-ups, you know what to do. In the meantime, we did receive one more. So I have today 6 BB embryos that they plan to transfer. What is your opinion on the quality of 6 BB success rates?
So BB 6, it is 6 day. I have today
2 day 6
6
BB.
BB embryos. Today 6 BB. BB, it's qualification give us it's a blastocyst, 5 days embryo. 6, it's like measurement of the big blastocyst. 2 embryos.
Yes,
Okay.
2 embryos. Sorry.
2 embryos of 6 BB embryos. So BB is a good quality. So 6, it's a big expanded blastocyst. So should be okay. Because the small blastocysts can stop and do not develop to the stage of the when it's the embryos coming out of their own shelf. Yes, but 6, it's a big embryos, and I understand 2 embryos. It's let's say big embryo, good quality, so should be okay. I wish you luck. First of all, should be healthy uterus. They should transfer these 2 embryos on the most success, like the best day of the pinopodium and secretory endometrium, and no infection, hormonal balance with everything. Prolactin is very important, vitamin D is very important, thyroid is very important. So if you do all of this, I think you should be okay.
All right. Sounds again very good. Thank you so much indeed for yet another
China,
advice.
China transferring much lower quality of embryo than Europa and Ukraine. So BB is very good quality.
Thank you so much for the reassurance. And of course, there's a thank you from Lisette for you as well. And in the meantime, we did receive a message. It's not a question, it's just a comment. So just wanted to express my gratitude to Dr. Viktoria. She is an amazing doctor, and I am blessed to have her as my doctor. Thank you so much for sharing. Glad to hear that as well. And obviously, I'm just looking, there are no more questions. However, remember that if you wish to get some more answers, get in touch with Dr. Viktoria. I'm sure she'll be happy to discuss it with you or check it. I know that doctors always need more details than just here. So don't hesitate. And I believe we will be finishing for today. But thank you so much, everyone, for your questions, for your time, and for joining us over and over again. Dr. Viktoria, this is your first webinar, but I'm looking forward to some more webinars coming up soon. And thank you so much. Anything else? Anything else you wish to add before we finish for today?
Thank you so much for everything. I'm very happy to be here, and I hope I will help someone with my answers. And if you have more questions, we will be happy to help you with successful pregnancy.
Thank you so much indeed. Thank you so much, everyone. And of course, remember, we will be back. Now we are going on a short summer break, but we will be back in September. So I hope you will be able to join us. We will be back with another topic with Professor Alan Thornhill. We will talk about what is the best clinic for you, what is the right clinic for you, so how to choose it. Alan will provide you with some tips, so don't hesitate to register on our website, My IVF Answers. And of course, remember, this has been recorded. It will be available tomorrow on our website. So we will be back in September. Have a great summer. I wish you all the best of luck, and I hope that we will get some final good stories after the summer, and you will be able to share some good positive news as well. So best of luck to you all. Dr. Viktoria, thank you so much once more. And yeah, have a lovely evening. Take care and see you soon. Bye.
Thank you. Thank you so much.